Here we have a superficial and lateral view of the skull and face. You can see that the skin has been removed. There is no deep fascia on the face, evidenced by seeing some of the muscles of facial expression quite clearly. The fascial structures that are important, however, are the temporal fascia, which is covering the temporalis muscle, otherwise called the temporal muscle, and a strong capsule overlying the parotid gland here, which is anterior to the ear, auricle, and overlying superficial to the temporomandibular joint. The capsule of this parotid gland actually goes posterior and to the deep surface of the mandible, attaching it to the styloid process. That part is called the stylomandibular ligament and is a passive support for the joint. The parotid, as I said, overlies the TMJ, which is about deep to where my probe is. It's the largest salivary gland and has a duct, which is not quite visible yet, but actually here it is. And this duct goes into the oral vestibule opposite the second upper molar to empty saliva. The important nerve branches passing through this are the temporal, zygomatic, buccal, marginal mandibular, and cervical branches of the seventh cranial nerve, the facial nerve. These nerves were not saved in this dissection, but they are important innervators of the muscles of facial expression, like the frontalis muscle, the orbicularis oculi, the zygomaticus major muscle, levator labii superioris, etc. The parotid gland also has important vascular relationships. The external carotid is deep, and you will see in subsequent deeper dissections will reveal some of these branches. At this point, we can see one of the terminal branches, the superficial temporal artery, as it's passing anterior and superior to the auricle. There is a vein of the same name. The artery is a terminal branch, as is the maxillary artery of the external carotid artery. The maxillary will be going deeper. We'll see that later. The venous drainage from the superficial temporal vein joins the maxillary vein and forms a vein called the retromandibular, which is just posterior to the angle and posterior border of the mandible. That retromandibular vein is going to empty into the internal jugular, which is deep, and here we'll see later. The muscles that move the temporomandibular joint that are now available at this level are the masseter, we'll see more when we dissect, and the temporal. There are two deeper, the pterygoids, which we won't be able to see until we reveal the infratemporal fossa.
At this point of the dissection, the parotid gland is removed, the temporal fascia is removed as well, and we have a full view of the temporal muscle, otherwise known as the temporalis. It's an old term. The temporal muscle has three distinct groups of fibers in relation to the temporomandibular joint. Primarily, it's an elevator and retractor, but the anterior fibers here can protract. Most of the fibers here are superior fibers, strong elevators, and you can see the transition to an almost horizontal group of posterior fibers. Let's look down here to the masseter. The masseter has two distinct groups of muscle fibers, the superficial and deep fibers. The masseter is a strong elevator. However, it can give a component of protrusion. The deep fibers of the masseter are vertical. All masticatory muscles are innervated by branches of the mandibular nerve. This is a trigeminal branch we refer to as V3. The mandibular branch of the trigeminal nerve leaves foramen ovale from the middle cranial fossa into the infratemporal fossa and gives many branches to the muscles of mastication, including the pterygoid muscles, which we will see soon. Recall that there are also depressors of the mandible, which are anterior. The external carotid artery is here. It is a terminal branch of the common carotid in the neck. The external carotid gives off 6 side branches as it ascends. 3 are anterior. We see from inferior to superior, the superior thyroid, the lingual artery, and the facial artery. The facial artery is somewhat unique in the amount of elastic fibers that it has. You can see it coursing over the inferior margin of the body of the mandible. Hence, with this increased number of elastin fibers, this allows for slack to be taken up in the actual vessel with these small convolutions in the artery, such that we can maintain blood supply to these facial structures during depression of the mandible. From this view, we are unable to see the ascending pharyngeal artery, which is the medial side branch of the external carotid. So again, our anterior branches include the superior thyroid, lingual artery, and the facial artery. The medial side branch of the external carotid artery is the ascending pharyngeal artery. Our 2 posterior side branches of the external carotid artery are the occipital artery as well as the posterior auricular artery. I can reflect the masseter here. Here we can see the ramus of the mandible. And you can see superiorly at the cornoid process where the temporalis, the temporal muscle, would be attaching. And the condylar process, particularly the head of the mandibular condyle, is articulating at the temporomandibular joint with the mandibular fossa of the temporal bone. In this lateral superficial view, we can appreciate 2 out of the 4 muscles of mastication, the temporalis and masseter muscles. It should be noted that the temporal fascia, as well as the parotid gland, have each been removed, so we can best visualize the muscle fibers of these 2 particular muscles. The temporalis muscle attaches proximally to the floor of the temporal fossa, as well as the deep surface of the temporal fascia, which again has been removed. Inferiorly, the temporalis attaches to the tip and medial surface of the cornoid process of the mandible, as well as the anterior border of the ramus of the mandible. The innervation of temporalis is provided by the anterior trunk of cranial nerve V3 via deep temporal branches. Deep temporal branches also give blood supply to the temporalis muscle. So the maxillary artery is one of the 2 terminal branches of the external carotid artery, the other terminal branch being the superficial temporal artery. The maxillary artery gives off 3 terminal branches: the deep temporal, the masseteric, and the pterygoid branches. So the deep temporal branches are going to give blood supply to the temporalis muscle. If we look at the muscle fibers of temporalis, we can see that predominantly these are vertically inclined. However, if we look more posteriorly and inferiorly on this particular muscle, we can see these muscle fibers taking more of a horizontal orientation. So what this tells us is that primarily the temporalis is going to elevate the mandible. However, its more horizontal and posterior fibers are going to be more so retractors of the mandible. So these are going to be our primary mandibular retractors. If we look more anterior and inferiorly relative to the temporalis muscle, we can appreciate the masseter. So the masseter attaches superiorly to the inferior border and the medial surface of the maxillary process of the zygomatic bone and the zygomatic arch. Inferiorly, the masseter attaches to the angle and the lateral surface of the ramus of the mandible. Innervation of masseter is provided by the anterior trunk of cranial nerve V3 via the masseteric nerve. We discussed the 3 divisions of the maxillary artery. So with these three divisions, the deep temporal, the pterygoid divisions, as well as the masseteric artery, hence the name, the masseteric artery will give blood supply to the masseter muscle. If we look at the muscle fibers of masseter, again, predominantly vertical, so again, going to be excellent for mandibular elevation. However, if we look at the more superficial fibers of masseter, we can see that there is a slight anterior inclination of this muscle in its particular line of action. Again, speaking to the superficial fibers. Hence, while there's an overwhelmingly dominant Y component to this line of action, hence this muscle being a very strong mandibular elevator, there is also a slight X, or in this case, anterior component. Therefore, masseter will contribute a small amount to mandibular protrusion. Depressors of the mandible include gravity, the anterior and posterior bellies of the digastric, the mylohyoid muscle, the geniohyoid muscle, and the platysma. So while gravity is the primary agonist with mandibular depression, that's non-forced mandibular depression. If it were forced mandibular depression, these other muscles would be recruited. In this submandibular anterior and inferior view, we can appreciate from midline laterally the digastric anterior belly, and then as it dips inferiorly, the intermediate tendon, which is joining the anterior and posterior bellies of the digastric, is really passing through the digastric sling, which is derived from the pretracheal fascia of the neck. So our anterior and posterior bellies of the digastric, just deep to the anterior belly of the digastric, we can appreciate the mylohyoid muscle. And if we were to reflect the mylohyoid muscle just deep to this, coursing along the midline, again a paired muscle, the geniohyoid muscle, deep to the mylohyoid, the paired geniohyoid muscle would be present. In order for these suprahyoid muscles to depress the mandible, the hyoid bone itself, or their inferior attachment, must be fixed. So how does this hyoid bone get fixed? Well, if we look inferior to the hyoid bone, or infrahyoid muscles, these longitudinal muscles will stabilize the hyoid via isometric contraction, so the suprahyoid muscles can depress the mandible. Most anterior and superficial, we can see the sternohyoid muscle. Reflecting this muscle inferiorly, we can appreciate the sternothyroid muscle more inferiorly, and the thyrohyoid muscle more superiorly relative to the sternothyroid muscle. And laterally, we can appreciate the omohyoid, both the superior and inferior bellies. It's important to note that the mylohyoid and the anterior belly of the digastric muscle, these are both derivatives of the first pharyngeal arch, like the major masticatory muscles, so temporalis, masseter, medial and lateral pterygoids. Hence, their innervation will be provided by the mandibular branch of the trigeminal nerve, or V3. Prior to entering into the temporomandibular joint, we can appreciate from lateral to medial the lateral ligament, or the temporomandibular ligament. These terms are synonymous. The lateral ligament has both an outer oblique portion as well as an inner horizontal portion. The outer oblique portion is a passive limiter to rotation of the mandibular condyle, while it's articulating posteriorly in the mandibular fossa. So if we look at the orientation of the outer oblique portion of the lateral ligament relative to the ML axis of the temporomandibular joint, we can appreciate that this ligament is inferior to this particular ML axis. What this means is, from a neutral temporomandibular joint position, with depression of the mandible, we will get an initial posterior roll of the mandibular condyle and an anterior glide. With this posterior roll, tension will be taken up in this outer oblique portion of the lateral ligament. At approximately 20 to 25 millimeters of distance between the incisors, this tension in this particular outer oblique portion of the lateral ligament will rise. Prior to any additional movement occurring, anterior gliding needs to take place. If anterior glide does not take place, there will be no further mandibular depression. The inner horizontal portion of the lateral ligament will limit posterior excursion of the condyle. So with sufficient force, the neck of the mandible is usually going to fracture before the head displaces posteriorly, secondary to the inert stability of this inner horizontal portion of the lateral ligament. So again, the mandible itself is the movable segment. The actual temporal bone is not moving. So based on the attachment points of this inner horizontal portion of the lateral ligament, it will be a prime resistor to posterior excursion. Additional passive support of the temporomandibular joint is provided by two extrinsic ligaments, the stylomandibular ligament and the sphenomandibular ligament. The stylomandibular ligament is a thickening of the fibrous capsule of the parotid gland. This ligament courses anteriorly and inferiorly from the styloid process to the angle of the mandible. This is going to limit excessive anterior and inferior translation of the mandible on the temporal bone. The sphenomandibular ligament runs from the spine of the sphenoid to the lingula on the deep surface of the ramus of the mandible. The sphenomandibular ligament is the primary passive support of the mandible with respect to the normal force against gravity. However, it's important to note that the normal resting tonus of the temporalis, medial pterygoid, and masseter muscles are also going to contribute to supporting the mandible against gravity. This is a sagittal view of a right temporomandibular joint. The temporomandibular joint is a modified hinge-type synovial joint and is ginglymo-arthrodial, a hinge-type joint that also has gliding properties. The hinge versus gliding properties are really due to not only the joint surfaces, but also the articular disc that is between them. So with respect to the temporomandibular joint, or actual joint surfaces, there's three of them, not including the articular disc. So the three joint surfaces not including the articular disc include the mandibular condyle, the articular tubercle, as well as the mandibular fossa. So with the addition of this articular disc between these structures, we get an additional two joint surfaces. So this disc itself is going to divide the temporomandibular joint into both superior and inferior cavities. These superior and inferior cavities are completely separate from each other. The morphology of the disc is biconcave, so if we think of something along the lines of a red blood cell, this disc isn't nearly as symmetric as a red blood cell, at least when you see it in the pictures. However, if we're looking at the overall dimensions of the disc, if we're looking at a sagittal section, roughly the intermediate zone of the disc, or the actual concavity, so the reciprocal concavity region of the disc in the central portion, this is roughly 1 millimeter thick. The anterior portion of the disc is roughly 2 millimeters thick, and the posterior portion of the disc is roughly 3 millimeters thick. So the joint itself is surrounded by a loose joint capsule. The joint capsule of the temporomandibular joint attaches along the periphery of the articular cartilage of the temporal bone, as well as the neck of the condylar process, inferior to the mandibular condyle. When we think about just what the mandible needs to be able to do in not only chewing objects, but as well as breathing, producing speech, it makes sense for there to be a loose joint capsule. That way there's free movement for the mandible to move and do these various things that are necessary for everyday function for us. When we think about the postglenoid tubercle being that posterior buttress relative to the mandibular fossa, as well as the articular tubercle, there's relatively good amount of stability anteriorly and posteriorly with this joint. However, medially and laterally, there isn't quite as much stability. Hence, this loose capsular ligament is reinforced by the stronger lateral ligament or the temporomandibular ligament that we talked about earlier. The articular disc of the temporomandibular joint is made of a dense fibroconnective tissue or fibrocartilage, so it has remodeling properties, which makes sense. If it did not have these remodeling properties, we'd have a significant amount of joint surface degeneration at a very early point in our lives. However, that's not the case because of this particular tissue property. It is because of the disc morphology and interarticular pressure that the articular disc is able to maintain its position relative to the mandibular condyle and the articulating surfaces of the temporal bone throughout a range of motion. With sagittal plane mandibular movement, the hinge movements occur between the disc and the mandibular condyle, and our gliding occurs between the disc and the articulating surfaces of the temporal bone, particularly the articular eminence. Blood supply and innervation of the articular disc is provided primarily to the periphery of the disc itself and not the intermediate zone of the disc. The last thing to discuss relative to the articular disc of the temporomandibular joint is the retrodiscal tissue. So this retrodiscal tissue is richly vascularized and innervated. It's comprised of loose connective tissue with a superior elastic lamina and an inferior collagenous lamina. In this particular dissection, we have removed a portion of the mandibular ramus so we can better appreciate the medial and lateral pterygoid muscles. Beginning with the lateral pterygoid muscle, this muscle has both a superior and an inferior head. The superior head attaches proximally to the infratemporal surface and the crest of the greater wing of sphenoid. The inferior head attaches proximally to the lateral surface of the lateral pterygoid plate. Distally, the superior head attaches to the joint capsule and the articular disc of the TMJ, and in some studies, it's been shown that the muscle also has attachment sites to the neck of the condylar process of the mandible. The inferior head attaches distally to the pterygoid fovea, which again, this particular depression is located on the anteromedial aspect of the neck of the condylar process of the mandible. Innervation of the lateral pterygoid is provided by the anterior trunk of cranial nerve V3 via the lateral pterygoid nerve. Blood supply is provided via pterygoid branches, which are from the maxillary artery. Again, the maxillary artery being one of two terminal branches of the external carotid artery. And what we mentioned earlier with when we were discussing the temporalis and masseter muscles and their blood supply, the maxillary artery has three branches relative to the lateral pterygoid muscle. These divisions again being deep temporal branches, the masseteric artery, as well as the pterygoid branches. Pterygoid branches supplying what the name of their artery is. So arteries are named based on their target. So our pterygoid branches are going to give blood supply to both the medial and lateral pterygoid muscles. The action of the lateral pterygoid muscle, when acting bilaterally, this muscle will protract the mandible, which will result in depression of the chin. When only one side is contracting, or it's a unilateral action, it will swing the jaw towards the contralateral side. So we can appreciate the relatively horizontal orientation of these muscle fibers. The medial pterygoid muscle has proximal attachments to the medial surface of the lateral pterygoid plate, the pyramidal process of the palatine bone, as well as the tuberosity of the maxilla. Inferiorly, the medial pterygoid attaches to the medial surface of the ramus of the mandible. Also has attachments to the angle of the mandible. Innervation of the medial pterygoid is provided by the anterior trunk of cranial nerve V3 via the medial pterygoid nerve. And we mentioned earlier that the pterygoid branches of the maxillary artery give blood supply to both the medial and lateral pterygoid muscles. The medial pterygoid is essentially a mirror image of the masseter muscle. However, the medial pterygoid is on the deep surface of the mandible. So we know if we're considering the muscle attachments, the medial pterygoid and the masseter, one attaches to the lateral surface of the ramus of the mandible, as well as the angle of the mandible, this being the masseter. On the deep surface of the mandibular ramus, the medial pterygoid. So with this mirror image and relatively symmetric orientation of muscle fiber, the medial pterygoid will be a primary elevator of the mandible. It's also going to contribute a small amount to mandibular protrusion as well. When discussing the temporomandibular joint, we often consider movements of the mandible in relation to agonist and antagonist directions. For example, elevation and depression, protrusion, retrusion, and then our different lateral movements for grinding and chewing. More specifically, we can group these movements functionally, for example, depression and protrusion, and elevation and retraction, as these are coupled movements that occur with those opening the mouth and closing the mouth respectively. In anatomy, a lot of the time, we study muscles based on their individual action. Rarely do muscles function, if ever, individually. So we always have some amount of co-contraction occurring or multiple muscles moving, turning on, turning off throughout a range of motion. Muscles have lines of action. Line of action is a force vector. Force vector has both magnitude and direction. With any osteokinematic motion, we can pause the frame and determine the particular vectors of each individual muscle. However, it's important to remember that these vectors are constantly changing throughout a range of motion, at least to some degree. And we know this because moment arms often change throughout a range of motion. Hence, the vector is going to change. We're going to next consider opening and closing the mouth. Opening of the mouth is accomplished primarily through the force couple between the inferior head of the lateral pterygoid with the suprahyoid musculature. Now, it's important to remember that the suprahyoids, in order to do their job and depress the mandible, or in this case, depress the mandible during opening of the mouth, the infrahyoids also need to be active in stabilizing the hyoid bone. So the suprahyoid musculature, so they have a nice stable base to produce movement. So proximal stability for distal mobility. In this case, proximal stability being muscle attachment sites at the hyoid bone, distal mobility being the inferior margins of the mandible. In a sagittal plane view, when you consider the line of action of the inferior head of the lateral pterygoid muscle, there's actually greater overall mechanical loading of the temporomandibular joint during mouth opening relative to unresisted mouth closing. However, there is not greater overall mechanical loading of the temporomandibular joint relative to resisted mouth closing. Closing of the mouth is accomplished through concentric activation of the temporalis muscle, the masseter, the medial pterygoid, and there's actually some functional role of the superior head of the lateral pterygoid in closing of the mouth. And what's the mechanism that it's believed to be is through maintaining active tension via eccentric contraction along at the anterior portion of the joint capsule. This, with closing the mouth, maintains the articular disc relative to the mandibular condyle. So it helps maintain that position of the disc on the condyle during closing of the mouth via that eccentric contraction of the superior head of the lateral pterygoid, while the temporalis, masseter, and medial pterygoid are actually driving the closing of the mouth itself. So there's a review of muscle action during opening and closing of the mouth. As with any of these mandibular movements, but especially with lateral deviation, and understanding force couples and just how lateral deviation is produced, it's essential to pay particular attention to the fiber orientation of both the posterior and inferior, more horizontally oriented fibers of the temporalis muscle, as well as the lateral pterygoid muscle, primarily. We'll talk about medial pterygoid and masseteric contributions and their role in lateral deviation, but first we're going to focus on just the temporalis muscle and the lateral pterygoid. So first, consider lateral deviation of the mandible to the left. The longitudinal axis that the mandible rotates on is always on the side that the mandible is deviating toward. We know, based on when we discussed the individual muscle action of the lateral pterygoid, that when acting bilaterally, this is the primary protractor, particularly the inferior head, but the lateral pterygoid is a primary protractor of the mandible. Now let's say both lateral pterygoid muscles are contracting, so that being the right and left lateral pterygoid, but now on one side you add in a posterior translatory muscle contraction or retraction, this being provided by the temporalis muscle. What we get here is on that side with temporalis muscle contraction, we now get a force couple about that longitudinal axis. However, the opposite side continues to protrude. So if we're considering lateral deviation of the mandible to the left, we know that primarily the left temporalis muscle and the left lateral pterygoid muscle are both contracting, creating a force couple about that longitudinal axis, and the right side of the mandible, or the right mandibular condyle, continues to translate anteriorly, which produces mandibular deviation or lateral deviation to the left. Now, these muscles are primarily considered to be the real primary movers with lateral deviation of the mandible. However, as we discussed, rarely do muscles work in isolation. So when we consider the muscle fiber orientation of the medial pterygoid as well as the masseter, particularly the superficial part of the masseter, we know that when we resolve the muscle fiber's line of action, we know that there is predominantly a vertical component, the y component dominating the x component. However, there is still that x component, in this case the x component being anteriorly directed. Anytime you have these x and y components, we have to consider that there's going to be movement across both of those particular axes. So while the y component of these muscles predominantly results in elevation of the mandible, there is still that anterior component or that x component of the particular line of action of these muscles that will result in small contributions to protrusion of the mandible. So while we often consider the temporalis and lateral pterygoid as our primary movers, it's important to know that the medial pterygoid and the masseter, particularly the superficial head, are also active in contributing to the protraction elements of lateral deviation on each side.
Neurovascular structures in the infratemporal fossa. The trigeminal nerve has three divisions. Passing through foramen ovale is the mandibular nerve. We call that V3. And this is the only division of the trigeminal that has branchial motor fibers. All of these masticatory muscles and other associated muscles have developed from the first branchial arch embryologically. So they have shared innervation from fibers of the mandibular nerve. As the mandibular nerve drops through the foramen ovale, it starts to give off many branches. We have branches to the deep surface of the temporal muscle, branches to the pterygoids, masseter. If you follow the inferior alveolar nerve, this is mainly sensory, but posterior, it gives off a branch called the nerve to mylohyoid. And that will, of course, go to mylohyoid muscle and anterior belly of the digastric. Of course, there's sensory nerves to all the mandibular teeth, the gums, and of course the skin overlying the mandible. For arterial supply in the infratemporal fossa, we'll be talking about branches of the maxillary artery. This is one of the terminal branches of the external carotid. It passes deep to the ramus of the mandible through the infratemporal fossa and then on through the pterygopalatine fossa. This artery is more or less horizontal, has three parts: a mandibular part, a pterygoid part, and then a pterygopalatine part. The muscles of mastication all receive branches of the pterygoid part. So deep temporal arteries to the pterygoid muscles, and the masseter, of course. Branches will reach up into the cranial cavity, namely the middle meningeal artery, and the many arterial branches on the palate, the greater and lesser palatine arteries to the superior teeth.